Assalamu alaikum wa rahmatullah. Good evening, everybody. Thank you to join us with the fifth online critical care course for non-ICU physician, day 3 and the last day of this course. Today we are going to start with acute kidney injury in the COVID-19. Dr. Mohammed Al-Udati will present this topic. Dr. Mohammed Al-Udati is ICU consultant. He is a clinical assistant professor of internal medicine in Al-Imam University. Dr. Al-Udati, can you start? Dr. Al-Udati? Hi, Dr. Al-Udati, can you start, please?
الو يلا بسم الله ابدا.
دكتور عدات.
السلام عليكم.
وعليكم السلام ورحمة الله. دكتور عدات.
احمد.
ايوه تفضل دكتور عدات.
احمد.
ايوه دكتور.
احمد.
دكتور.
كده سامعني؟ الو. يلا ماشي. السلام عليكم. Good evening everybody. I'm Dr. Mohammed Al-Udati, ICU consultant. We will talk about the acute kidney injury, which is previously called acute renal failure. The definition of the acute kidney failure: this is a sudden and often reversible reduction in the kidney function, and this is measured by the glomerular filtration rate and GFR, or the creatinine and urea. Actually, there is no clear definition of the acute kidney injury. However, there is several different criteria have been used to the research studies, such as a rifle criteria, acute kidney injury, and kidney disease improving global outcomes criteria, which is defined as acute kidney injury if presence of any of the following: increase in the serum creatinine by 0.3 milligram per deciliter or 6.4 microgram per liter within 48 hours. Another criteria, if the increase in the serum creatinine to 1.5 times or more within the 7 days, or the urine output, urine volume less than 0.5 ml per kg per hour for at least an hour. The definition according to the kidney disease improving global outcomes criteria. And this criteria nowadays, this is the most recent and most commonly used criteria using nowadays to define acute kidney injury in general. The incidence of the acute kidney injury is a very common condition among hospitalized patients hospitalized patients will develop acute kidney injury, and 30% of the ICU admission will develop acute kidney injury. 15% of the patients admitted to the ICU will need continuous renal replacement therapy. Actually, the acute kidney injury in the COVID-19 patients is still unclear, the incidence, but incidence between 9% to 23% according to the recent studies in the COVID-19. But it's still this a common, and it's very important to know about the acute kidney injury, because the acute kidney injury, if the patients developed, the mortality rate will increase. Usually increase the mortality rate more than 28%, the mortality increase if the patient developed acute kidney injury in patients with COVID-19. In general, causes, the etiology of the acute kidney injury, as you know, this is the pre-renal, renal, and post-renal. And the pre-renal, this is the hypovolemia, hypotension, septic shock, and this is the COVID-19 will be in this most likely because of the septic shock and multi-organ failure. The patients will develop acute kidney injury due to COVID-19 in this area. Also, this is will lead to the ischemic ATN, which is acute tubular necrosis. So most likely this is the two causes of the COVID the patients will develop acute kidney injury due to the pre-renal and renal, which is ischemic ATN. Now I will talk about our case. This is the first case admitted with a COVID in our hospital. He is a 65 years old male patient, seen on diabetic, hypertensive, all CVA. He presented to the ER with chiefly complaint fever, cough, shortness of breath. Patient immediately admitted to the isolation room because of this pandemic. Nowadays, this pandemic. So they sent for him a COVID-19, and they found positive COVID-19. And this is the first patient was diagnosed. They did, of course, X-ray, and they found bilateral infiltration. As you can see from this X-ray, this atypical findings of the chest X-ray findings with peripheral infiltration, bilateral infiltration. So this patient seen by the ICU, he was conscious, oriented, but the tachypneic respiratory rate was 30 per minute. A temperature was 38.5. He was hypotensive little bit, the blood pressure 80/40 with MAP of 56. Of course, this patient, when we saw him as ICU team, immediately we intubate the patients, connected to mechanical ventilation, and this patient was in high sitting. Of course, we have to monitor the urine outputs, and we found the urine outputs at 20 ml per hour, which is low. And according to our criteria, if you remember our criteria, if the urine output less than 0.5 ml per kg, this is acute kidney injury. Of course, they sent for him the kidney function. Creatinine was high, 350. Urea was 25. This was previously normal. So this patient was diagnosed as a viral pneumonia, COVID-19 with ARDS. He met the criteria of the ARDS. Of course, they did for him ABG, and he met the with acute onset bilateral infiltration, and he met the criteria of ARDS. And septic shock, he was in inotropic support, and of course, acute kidney injury. Acute kidney injury. Okay, so what the cause of the acute kidney injury patients develops? This patient's most likely he develops septic shock, sepsis, hyperperfusion, pre-renal azotemia with hyperperfusion of the kidney. So this is the first cause, pre-renal due to septic shock. So this is the cause why patients develop acute kidney injury. What the goal of the management of the acute kidney injury of these patients? Of course, any patients admitted to the ICU, we have to monitor these patients' respiratory and hemodynamics and kidney. We have to monitor the urine output 24 hours. The patients will send for him, of course, ABG. We will do for this patient all the investigation, and we will follow him in the ICU. We will insert for him arterial line, CVB line, to monitor this patient 24 hours. Of course, any patients develop acute kidney injury, we have to adequate rehydration. We will give the patients the challenge test to give IV fluids to maintain the perfusion to the kidney. Of course, we have to avoid nephrotoxic drugs because that will be another insult of the kidney, and we have to avoid the nephrotoxic drugs and contrast, of course, to avoid another injury to the kidney. The monitoring of the labs, we have to monitor the patients 24 hours. We have to monitor the kidney function, liver function, and in these patients, we have to monitor the D-dimer, of course, because of the severity of the COVID-19, the D-dimer, LDH, ferritin. These patients, we have to send for him because of the severity of the COVID-19. Of course, the CBK also. The continuous renal replacement therapy, this is still the treatment of choice for patients with complication of acute kidney injury. And we will talk about the indication for the continuous renal replacement therapy in the next case. Which mode of the continuous renal replacement therapy will use? Usually, we are using the continuous veno-venous hemodiafiltration with cytosol filter, and we believe that these patients developed multi-organ failure with cytokine release, cytokine storm. So we have to remove all these cytokines. So the mode of choice will be the CVHDF with cytosol to remove all the cytokine and pro-inflammatory mediators. So this is the mode of choice for these patients. Another case, this patient is not COVID-19, but he is RTA, for 45 years old, admitted to the ER after the RTA. He has a massive abdominal trauma with fracture femur. Patient was taken to the OR for bowel perforation and liver laceration. He received 4 units packed RBCs, and the 5th unit was discontinued in the ICU due to transfusion reaction. On the day after the surgery, his urine output decreased to 10 to 20 ml per hour. So according to our criteria, if this patient developed according to our criteria, this patient developed acute kidney injury because of the urine output decrease less than 0.5 ml per kg. This patient was resuscitated with a fluid intake, but the urine output didn't improve. The patient we sent all the investigation for the patient. Of course, urine sodium, urea was high, creatinine was high, 400, urea was 20. On the day 3, his urine output is still 25 ml per kg. And of course, according to our criteria, this patient was diagnosed acute kidney injury. And because of the persistent hyperkalemia, this patient started in hemodialysis, CRRT. And we found this the CK very high CK because of the crush injury, because of the trauma. So the cause of the acute kidney injury in this patient was trauma due to rhabdomyolysis with hyperkalemia also transfusion reactions, hypovolemia. Also, this patient was hypovolemic, so multifactorial toxicity of the livers. So this multifactorial patients developed acute kidney injury. What the clinical indicators Muhammad has in oliguric phase of the acute kidney injury? Because decrease urine output less than 30 ml per hour. So this is the criteria patients diagnosed as acute kidney injury. Decreased urine output less than 30 ml per hour. To what do we have to give attention? Of course, this we have to give attention for rhabdomyolysis to avoid good dehydration. We have to avoid hyperkalemia also because of the complication arrhythmias, and you have to manage the patient electrolytes, potassium. You have to manage the fluid overload, tissue perfusion, and of course the high risk of the bleeding of these patients. What the goal of the management of acute kidney injury of these patients? Of course, monitoring on the ICU 24 hours. We have to monitor the urine outputs, arterial line, CVP line, of course the electrolytes, the fluid balance. We have to give the patient adequate dehydration, replace the blood as needed. You have to prevent the infection, and we have to monitor the lab frequently. What is the usual indication for dialysis in acute kidney injury? Actually, the acute kidney injury, the indication, if the patient anuric, oliguric, the urine output less than 200 ml per 24 hours, usually not responding to treatment, we are do for him CRRT, hyperkalemia, persistent hyperkalemia, not responding to medical treatment, severe acidemia, if the pH less than 7.1, azotemia with uremic symptoms, organ edema, and especially this is the lung, acute pulmonary edema because of the fluid overload. Of course, uremic symptoms, uremic encephalopathy, pericarditis, uremic neuropathy, and uremic myopathy. Drug overdose, you can remove the drugs by the CRRT and hyperthermia. This is the usual indication for the CRRT, which is the continuous renal replacement therapy. This patient has a CK of 40,000. So which mode of the dialysis will you will choose? Of course, we have 4 mode of the CRRT: SCUF, CVH, and CVHD, and CVHDF. This patient, the CK, this is the myoglobulins, and the myoglobulins usually this is large molecules, and the large molecules need conviction, need mechanism of conviction, and the conviction mechanism will be in the patient in the mode of continuous veno-venous hemofiltration, which is the CVH. Also, if this patient develop septic shock, you can combine use CVHDF also. So if you want to remove all of the myoglobulins, you can use the CVH, which is the conviction mechanism, the CVH, continuous veno-venous hemofiltration. Of course, of the renal, we have to talk about the contrast-induced acute kidney injury. And contrast-induced acute kidney injury is predominantly via the acute vasoconstriction. And there is a risk factors for the contrast-induced acute kidney injury. And this is very important to know because we are doing a lot of investigation. We are using a contrast, and this contrast can induce acute kidney injury. So there is risk factors if the GFR less than 35 ml per minute, if the patient diabetic with diabetic nephropathy, if he is ischemic heart disease with congestive heart failure, large volume of the contrast, of course, this is risk factors. The patients will develop acute kidney injury. Of course, if the patient is hypotensive or hypokalemia. So if you will send the patients to do any investigation with contrast, you have to avoid the hypotension, hypokalemia. You have to correct you have to know about these risk factors. If the investigation is unnecessary, you have to avoid these investigations. Of course, we have to know about how to prevent the contrast-induced acute kidney injury. This is, of course, the most important, the IV fluid, which is crystalloid. You have to give before the procedure 1 to 1.5 ml per kg per hour for 8 to 12 hours before the procedure. This is the most safe and effective prevention of the acute kidney injury due to contrast induced. The administration of the N-acetylcysteine is still equivocal. It's still we are given, but the result is same. Yani there is no any it can help, but this is still not the type of the contrast. The type of contrast is very important also to know to avoid acute kidney injury due to contrast. What's the management of and goal of the acute kidney injury? We have to focus to correct the reversible causes. As we know, the acute kidney injury is a reversible disease. So if we treat the underlying cause, we can avoid the acute kidney injury, and the patient will be managed if we will treat the underlying cause. But still, if the patient developed a complication, the renal replacement therapy remains the cornerstone of management of patients with severe acute kidney injury. Usually the COVID-19, the patients will develop severe acute kidney injury. In the previous report of the SARS and MERS coronavirus infections, acute kidney injury was developed in 5 to 15% of the cases, and the mortality was very high. If the patients developed acute kidney injury, was 60 to 90% a mortality rate. And we suspect in the COVID-19 patients, if he will develop acute kidney injury, the incidence until now it's low, but we suspect this incidence will increase and the mortality will increase. But until now the study is going on, but we suspect that acute kidney injury in the COVID-19 will increase, the incidence will increase, and the mortality will increase. And there is association between the acute respiratory distress syndrome, ARDS, and acute kidney injury. A lot of cases develop ARDS and they will develop acute kidney injury. So we have to prevent the acute kidney injury and to manage it early. The current treatment of the COVID-19 with acute kidney injury is still the general supportive management, and if the patient developed complication, the renal replacement therapy, this is the treatment, and you can add the cytosorb to remove the cytokines. Thank you. I finished my presentation. Ahmed, I can.
Thank you, Dr. Adat, for your presentation. If there is anybody have any question, they can write in the chat, or just they can raise the hand to unmute them and they can ask. Actually, there is no any question until now. There is just Dr. Abdurrahman Nasir, he's raising the hand, so we'll unmute him.
ما سامع أنا ما سامع.
Dr. Abdurrahman Nasir, he has a question.
Assalamu alaikum. Ahla sahla. So is the continuous venous hemofiltration is the only way we're gonna use, or any only hemodialysis we're gonna use with COVID patients, or we can use others?
So your question about which modality of dialysis we will use in the COVID-19, CVHDF, you mean?
Yeah.
So Dr. Odad, this is the question. This is the only mode we can use it in COVID-19 patients, CVHDF?
Hello. CVHDF الفكره في الكوفيد 19 اللي هي السيتوكين ستورم. لهذا السبب we have to use the mode which is the mechanism to remove the large molecules with the cytokines, the pro-inflammatory mediators. So the choice, the mode of the choice of the CRRT will be the CVHDF. Why? Because to remove all the cytokines, which is the pro-inflammatory, which is large molecules. If you use the another mode, you will not remove, so will not help you in the management. So there is another also, you will add cytosorb to remove all these mediators. The better to use CVHDF and the cytosorb. This is the mode of choice.
So there is another question. 7% of hospitalized patients developed acute kidney injury. It sounds high.
7% of hospitalized patients, yes.
They developed acute kidney injury, and they think it's high percentage.
High percentage?
Yeah, 7%.
No, this is not high percentage. 7% of the hospitalized patients this is in the last acute kidney injury nephrology network. It is not so this is not it's high, of course, and you know that the acute kidney injury, it's common, and the patients will develop acute kidney injury. A lot of cases the kidney will affect it. So the 7% of hospitalized patients and 30% of the ICU admission. This is the incidence now. And there is another also. This is another. The incidence will be more. They are writing there is 5, there is 10%. This is will be depend on the hospitals. But this is a common disease, acute kidney injury, of course.
Now the question, the acute kidney injury in COVID-19, it's mainly related to cytokines storm or something else?
Okay, this is not until now. There is thrombi. Maybe the patients will develop a thrombus, and the kidney will, per se, will affect it, and the patients will develop hematuria and proteinuria. The kidney will, per se, will affect. But until now, this is not approved. Still, the mechanism, it's because of the hyperperfusion due to multi-organ failure, and the patients will develop acute kidney injury because of the cytokine storm and multi-organ failure. So the mortality in these patients very high if the patient will develop acute kidney injury because of the multi-organ failure, usually associated with ARDS. The another mechanism, still it's not approved. The COVID-19 will affect the kidney because, the COVID will affect, of course, the lung, the heart, and the kidney. But until now, still this mechanism is not approved. It's not approved. So, regardless, what's the cause of the acute kidney injury? We have to prevent this acute with good dehydration, avoid, of course, drug toxicity, good dehydration, avoid contrast because of the, if unnecessary, is very important in the acute kidney injury. Okay.
There is any rule of biosolvan for the contrast induced acute kidney injury?
Until there is no, but I don't know. Yani, there is role of the contrast-induced acute kidney injury to prevent. Still, the good dehydration and avoid hypotension, electrolyte replacement, avoid hypokalemia. This is the most important and effective management. The contrast also, can help and prevent the acute kidney injury, and to avoid the investigation in patients with high risk of acute kidney injury. This is the most important in the contrast-induced nephropathy.
Thank you for your presentation. Actually, it's very informative. Thank you so much.
Okay, thank you. Salam alaikum. Thank you. Salam alaikum.
Thank you for Dr. Adat for his presentation. Actually, it's very informative. Now we will move to Dr. Saima Shahzad. Dr. Saima, she's ICU consultant. She will discuss about the CPR dynamic in COVID-19. So, Dr. Saima, can you start, please?
Assalamu alaikum.
Walaikum salam. Yes, Dr.
My voice is clear, huh?
Yeah, it's clear. You can start.
Okay. Good evening to all. I hope you are all enjoying this fruitful sessions for COVID-19. I'm going to speak about CPR dynamics in COVID-19 as Dr. Ahmed Kohel has informed. And my objective will be to rapidly just recapitulate American Heart Association advanced cardiac life support guidelines with you people. And you will be able to understand the importance of team dynamics and the role as a team leader or as a team member during the CPR in the COVID-19 patients. And briefly, we'll go through the guidelines for the CPR in patients with suspected or confirmed COVID-19, along with the precautions which we should use in these patients. So, as all of you are ACLS providers, I believe this is a very important slide and is common to, it is like you are all familiar with that. Yes, I'm going to talk about the chain of survival. It is an internationally recognized standards of early interventions, which when given to a victim of sudden cardiac arrest, the best chances of survival if they are implemented early. So basically, these are the series of actions that should be manifested rapidly in an integrated manner during the cardiac arrest. So it consists of early recognition and activation of emergency response system, early high quality CPR, early defibrillation, and advanced cardiac life support, followed by the post resuscitation care for the patient. As we are talking about high quality CPR, there are 5 important components of high quality CPR as endorsed by the American Heart Association, which consist of a rate of at least 100 to 120 compressions per minute. That's why I would say push hard and push fast. Hard means at least more than 5 centimeter. That is the more than 1/3 of the anterior posterior diameter of the chest, allowing the complete chest recoil in between the compressions with minimal interruptions and adequate ventilations. It is important that every 2 minutes, the compressor, they should be rotated or even sooner if they get fatigued. And the pulse check should be done after every 2 minutes. As we all know, the teamwork makes the dream work. And a successful team is a group of many hands and one mind. Basically, these are not only having the medical expertise or they are master of resuscitation skills, but they also demonstrate effective communication and team dynamics. So whenever there will be a code blue while you are with us, rotating with us during this pandemic, so you will be the initial responder and you have to act like a team leader till another senior will come over and will take over the situation. So basically, the team leader should have a good situational awareness. And he is the one who will organize the group, will monitor the individual performances of the team members. He is a backup for his team and is a model of excellent team behavior. Is always involved in the training and coaching of his team members. And also, he is paying attention to whatever is going around. He's not only fixed to one problem. So, as a member of the team, we must respect this authority of the team leader and should be prepared to carry out the instructions for the leader. As we all know, the poor leadership, it will induce frustration, anxiety. It will also have a negative impact on the team and its future performance. So as a team leader, he is having a comprehensive patient care in his focus. But the team members, as a team member, we should focus on the individual tasks. So whenever we are the team, we must be clear about the roles which are designated to us and should be ready to fulfill the roles and responsibilities. And we are well practiced in this resuscitation skill and knowledgeable about the algorithms and for sure committed to success. While we move to the team dynamics, these are basically the operating forces within the team. And it consists of some important components like closed loop communication, clear messages, clear roles and responsibilities, knowing limitations, knowledge sharing, constructive intervention, re-evaluation and summarizing, as well as mutual respect. As we speak about communication, we know effective communication is essential, particularly in the times of high stress. And when we talk about effective communication, we are mentioning to closed loop communication. Closed loop communication is important as it reduces errors by removing the ambiguity. It allows the questions if the instructions were not clearly heard or these are not given properly. Basically, in a closed loop communication, the team leader will ask for a procedure by naming the member, and the member will reconfirm it by asking, and he will do the procedure and acknowledge to the team leader that it is done. So the closed loop communication is a very important pillar of effective team dynamics. Similarly, the clear messages, they play a very important role. The team leader must deliver the messages in a clear and consistent way with a controlled tone of voice, must be in a calm way, without yelling, shouting, or without anger. As we all know, the unclear communication, it will lead to delay in the treatment and also it will lead to the medication errors. Like suppose I want to give adrenaline to the patient during CPR, I can, if I say Asma, give adrenaline, it is not appropriate. It's not a clear message. Instead, it's better to ask her, Asma, give adrenaline 1 is to 10,000, 1 milligram IV push. And she will respond me back by telling adrenaline 1 milligram IV push given. So this is an example of not only closed loop communication, but also the clear messages. So if we move on to clear roles and responsibilities, these are very important to avoid the inefficient team dynamics. As we know, unclear roles will lead to multiple members of the team doing the same task and will miss the essential task. The team leader must clearly delegate the roles at the beginning of the CPR and should break down the boundaries between the individual with varying level of experience. If is unsure about the responsibilities, do not assign. And if during the CPR, if we need to have additional responsibilities for any member of the team, we should communicate with the team members. And this is the role of the team leader. As you know, the minimum number of people which are required for the effective team dynamics during the code blue is 6, including the team leader. So there is team leader who is at the foot end of the patient, along with one responsible for the airway and breathing, and the one member is responsible for the chest compression. One is taking care for the defibrillation along with the compressor. So he will alternate with the first compressor. One is responsible for the vascular access along with the medication delivery, and one is responsible for the documentation. But as we'll be speaking about the COVID-19 patients during cardiac arrest. Here, as per all the recommendation by American Heart Association, as well as Resuscitation Council of UK and the European Resuscitation Council, they emphasize on limiting the number of the people who are present in the patient care area. So minimizing the exposure risk to the staff, so keeping in mind the safety of the staff. So we have to limit the number to as minimum as 4, which are required for the essential care of the patient. If we go further in understanding the team dynamics, we have, I would like to go quickly through the other terms like knowing limitation. As I told before, it is basically the ability of the team member to know his competency, like to ask for help early before the situation gets out of the hand. Like someone who's unable or unable to get an IV access, then should stop trying again and again and should ask for help early, so should not delay. Similarly, someone who is not confident enough for endotracheal intubation can maintain the oxygenation with ambu mask until an experienced doctor will come and will take over. This is known as knowing limitations. The fixation error basically refers to sudden stuck on the skills or knowledge when working with stress. Like you, as a team leader, sometimes may become trapped in a specific treatment or diagnostic approach and will unable to progress till we remember that particular piece of information. This is known as fixation error. So how to solve the fixation error? The answer is simple: sharing the knowledge. So getting the contributions from everyone in the team, it can solve the fixation error. So whenever the resuscitation efforts are getting ineffective, go back to the basics and talk as a team. The team leader, if asked for the differential diagnosis, identify and go back to the reversible causes, which are the H's and the T's of the cardiac arrest. So, as a team leader, we should not ignore the suggestions for the treatment by the team members, and we should never fail to examine the signs relevant to the treatment. So, fixation error, if we face any time, the knowledge sharing is the key to solve it. Similarly, like during a resuscitation, if any action is inappropriate at that time, or any drug which is advised to be administered is incorrect or incorrect dose, we can attempt to stop it in a very tactful and a professional way while correcting the person, and to suggest for an alternative drug or a dose in a confident manner. This is known as constructive intervention from the team members. And debriefing at the end of the CPR afterwards, it can help in improving the learning as a team. So always practice for briefing and debriefing. Similarly, the role of team leader for re-evaluating and summarizing the CPR is very important. By he will give the periodic update to the team regarding the status of the patient, the interventions that have been performed, and assessment findings. He will re-evaluate the status of resuscitation attempts and will announce the plan for the next few steps. But always keep in mind, its ICU is very dynamic, so remain flexible to the changing treatment plans and revisiting the initial differential diagnosis for the patient. The mutual respect, it cannot be overemphasized. The best teams always work together in a collegial and supportive manner. They must abandon the ego and overconfidence, regardless of any additional training or experiences that the team leader or specific team members may have. So must always speak in a friendly and a controlled tone of voice, should avoid shouting or displaying the aggression, and we must acknowledge the efforts by saying thanks or good job. So this is the algorithm, which you can see. It looks very crowded and busy, but it's very important, and I will try to make it simple for all of you. As you all know, the interim guidelines were released by Resuscitation Council of UK. It was published on 23rd of March, 2020, and it was followed by the guidelines from the American Heart Association, which were published in mid of April. Both of these guidelines, they are emphasizing the safety of the healthcare workers on the top. So I was really liking this algorithm from the RCUK. That's why I will base my discussion on it. These are the similar guidelines which are endorsed by the American Heart Association also. So if you see on this screen, on the left side, there are mentioned phases, phase 1, 2, and 3. So this is not only depicting the level of care during the CPR, but also the level of the personal protective equipment which you must be wearing in different phases of the CPR. So like in phase 1, no specific person protecting equipment is required. Why? Because this is basically dealing with the decision making, conversations on the emergency management and the patient plan of care. So it can be performed even without any specific PPE. But in the phase 2, at least level 2 PPE is required, which is recommended as disposable gloves, disposable apron, along with the fluid resistant surgical mask and disposable eye protection. While in the phase 3, which is dealing with the aerosol generating procedures such as intubation, chest compressions, here we require level 3 aerosol generating PPE, which consists of disposable gloves, disposable gown, along with the filtration respirator and disposable eye protection. So now if we go in details of this algorithm, the most important focus from the Resuscitation Council of UK is about the decision making regarding the further treatment and the treatment escalation for the patients who are confirmed or suspected COVID-19. And this is why, because they want to avoid any unexpected cardiac arrest and unprotected CPR in order to decrease the risk of exposure to the healthcare workers. So whatever the decision regarding should, in case if the patient is not for active chest compressions, it must be.
Saima, can you share the presentation again, please?
Okay. No, it's clear?
Yes, it's okay now.
Yeah. So if there are no definitive PPE required for aerosol generating procedures, you are not supposed to start the chest compressions. It is very clear. So until unless you are not wearing the level 3 PPE, what you can offer to the patient is maximum the pulse check and the shock in case of shockable rhythm. So if you see, if the patient is not for CPR, it should be documented well, it should be communicated with all the team members, and the patient will enter into the end of life care according to the institution policies. But if patient is for full support, we'll assess for the unresponsiveness, or if the patient is not breathing normally, we'll call the resuscitation team and we will have to state the COVID-19 risk. It helps the team who is arriving to come in the full PPE as per the aerosol generating procedures. We'll assess the rhythm. We are not going to listen or feel for the breathing. We'll assess the pulse, carotid, and we'll see if the patient is showing the shockable rhythm, which is the VF and pulseless VT, we can deliver the shock to the patient. If we are in level 3 PPE, we can start the compression followed by the shock as per the usual algorithm. But if we are in the phase 2 of this algorithm with the level 2 PPE with the surgical mask, what we can do maximum is to deliver the shock followed by maximum of 3 shocks till the help will arrive, and the team with the particular PPE will come and will take over the situation. If the patient is having non-shockable rhythm like PEA and asystole, we'll wait for the team, or we'll go and don the level 3 PPE and we'll start the chest compression for the patient with minimal interruptions. So during the CPR, the recommendations are the same to a high quality CPR, minimal interruptions, give oxygen. If patient was already on oxygen with the face mask, what we'll do, we'll leave the face mask on and we'll continue with the compressions until the competent and the definitive member of the team is there to intubate the patient. So only indication to interrupt the compression will be during the intubation. Once there is return of spontaneous circulation, the immediate post-cardiac arrest care will be offered to the patient. We'll go with the ABCD approach. We'll aim for a saturation of 94 to 98%, and we'll take blood gas followed by the 12-lead ECG. We'll look for the precipitating causes, and we'll apply targeted temperature management for the patient. And if any intervention is required, like intubation, we should be in the proper level of PPE for that intervention, which is for the aerosol generating procedures. The special consideration which we can use in these patients, like we can consider ultrasound imaging. We can go for mechanical chest compressions to facilitate the transfer as well as the treatment, and also to minimize the risk of exposure for the healthcare workers. Similarly, coronary angiography or PCI as indicated, and extracorporeal CPR can also be considered in these patients. Just only for your recapitulation, I would like to go for the reversible causes, which are H standard T's. So always look for the reversible causes, which include hypovolemia, hypoxemia, hyperhypokalemia, acidosis, and hypothermia, and the T's, which include tension pneumothorax, cardiac tamponade, acute MI, or massive pulmonary embolism, and toxins. So again, here I would like to emphasize, while we are dealing with the confirmed or suspected cases of COVID-19, it is very important to consider treatment escalation and resuscitation decisions for all the inpatients. So recognize the cardiac arrest. Do not put your face near the patient face to listen and feel for the breath, and call for the help whenever you are calling help. State the risk of COVID-19. We'll attach the defibrillator and will shock if indicated. And there is a great emphasis upon on the defibrillation in all the guidelines. Uh, as we know already, the early defibrillation is an important link in the chain of survival. And if it is applied early within first 5 minutes of the cardiac arrest, it improves the chances of survival by 50 to 70% in these patients. And for every 1 minute delay, there is 10% less chances of survival. And similarly, it is not an aerosol generating procedure. If you check for the pulse and apply and you defibrillate the patient, this doesn't require level 3 PPE. And mostly early restoration of circulation may negate the need for the chest compression and ventilation in these patients. So there is a specific emphasis on the early defibrillation for those where it is indicated. After donning the appropriate PPE for aerosol generating procedure, we can proceed for the chest compression and airway procedures. Without that, no chest compressions or airway procedure should be done. If patient was not intubated, as I told before, leave the face mask on the patient face for oxygen, and you can proceed for only compression, chest compression only, and will restrict the number of the staff always. And while securing the airway, it must be by the most experienced and the competent member of the team, in order to decrease the number of the attempts which are taken, and or to decrease the aerosol generation during the intubation. It is suggested to use a video laryngoscopy if available, and before intubation, if it is necessary to use a bag mask device, it should be used with a tight seal and a HEPA filter. Ideally, it is recommended to avoid, but if it is really indicated, you can proceed but with a filter, and minimize the closed circuit disconnection, and intubate early with a cuffed endotracheal tube, and then connect to the mechanical ventilator whenever it is able to be connected. So only interruption in the compressions during the intubation. So as I told, identify the reversible causes of cardiac arrest, which are the S and the T's, and dispose of or clean all the equipment used during the CPR. Like if you are using the video laryngoscope, don't leave it tucked under the pillow of the patient. It should be placed on a specific tray or a table and can be disposed of according to the infection control recommendations. Similarly, the yanker, which is used for the suction, it should not be left on the bed of the patient. It should be put in a disposable glove, supposedly, and then can be disposed of according to the recommendation from the infection control. And whenever you remove the PPE, you have to make sure the safety first. So it should avoid self-contamination, should be disposed of in the clinical waste bags, and should be perform hand hygiene always. And post-resuscitation debriefing is very important. It helps to improve the efficacy of the team, also allows for the bonding between the team. So this is the final and the last slide. Here again, I will emphasize on the decision making. So conversations and the treatment escalation planning, it must be prioritized and individualized, and it must be documented and well communicated between all the members of the team. Whenever there is a plan to proceed for do not attempt CPR, it should be clearly mentioned and it should be clearly documented. Early identification of suspected and confirmed COVID-19 patients who are at the risk of acute deterioration or cardiac arrest. It is important because these patients then should be moved to the appropriate level of care early. where all the facilities and the trained staff is available in order to avoid unanticipated sudden cardiac arrest and unprotected chest compressions or the CPR for the safety of the healthcare workers. So I will like to conclude my lecture here. If you have any questions, I will be happy to answer. And I hope you are able to get the message.
Thank you, Dr. Saima. I have just some questions, actually, regarding if the patient in the prone position and the CPR, what we should do.
So I was supposed to touch this all issues, CPR in the prone position and in the pregnant lady. It's a very good question. I was expecting it really. So while if patient is in prone position, we can still continue with the chest compression, and the position will be the same in the interspinous area. But if you feel turning the patient will be less, it is less worrisome for all of you. You have the enough team and you can make the patient supine for continuity of care, it will be the best. But if no, you can still continue the chest compression in the prone position. It will be the same, nothing specific in the COVID-19. If you want to apply the defibrillator, it will be biaxillary. The pads will be applied, and biaxillary is very important rather than anterior and posterior, because once you turn the patient supine, still you will be able to defibrillate the patient.
There is, I think there is no question until now. So, but regarding the infection, as everyone is worried about during the CPR for the transmission of infection because of the aerosol, and regarding the ambu bag during also the intubation. During already, if the patient is intubated, especially. If
the patient intubated, no need to worry. You have a HEPA filter or the viral filter attached. So you will attach the ambu distal to the viral filter. It's not going to cause that level of aerosolization. Again, if it is indicated that you have to do the ambu bag, you can do it once the filter is there and the tube is there. And you are having appropriate PPE, level 3.
Regarding ambu bag during, if not intubated,
it is highly risky. Highly risky. It will lead to the aerosol generation, and it will risk all the staff who is present in the room, as well as the operator.
So you recommend to put the non-repeating mask until to be intubated?
Yes, it is the ideal. If the patient was on the face mask already, don't remove that. Keep it there till you have the team who can go for the airway precautions and procedures, or the rebreather mask. If patient was not on before, you can apply. So it will also limit the generation of aerosol.
Thank you so much, Doctor.
Welcome. I will still be available if somebody has a question.
There is one question. There is one question again. When I can start the compression?
When you can start the compression if you are in the level 3 PPE. This is clear. Like if you are not having your fit mask respirator, you are not wearing appropriate PPE, you can do maximum for the patient is the pulse check and shock the patient if it is a shockable rhythm. If it is a non-shockable rhythm, you have no option. Either you go out and wear appropriate PPE to attend the patient, or wait for the team with the proper PPE.
Okay, thank you so much, Dr. Saima, for your informative lecture.
Welcome. Welcome.
So now, actually, we will move to Dr. Walid. Just
Assalamu alaikum.
Dr. Walid, thank you, Dr. Walid. Just note, Dr. Walid is one of the master people in airway management in the ICU. Usually he's our instructor for all physicians. We are learning a lot of from him. So he's the selected doctors to train all of us, and who's the non-ICU physician. You will enjoy with his lecture. Even we are attending every time, but we are still enjoying with his lecture. So Dr. Walid, can you start please?
Yes, Dr. Ahmed, thank you very much. This is more than I actually deserve. I will try to stick to my time limit. So it's a bit lengthy, but I'll do my best.
Thank you, Dr.
So good evening, everyone. I'll try to share my screen. Yes. Okay, this is usually a workshop, hands-on workshop, but due to the current situation, we try to convert it into a lecture. So I try to insert some demonstrative videos. My name is Walid Al-Itribi. I'm an ICU specialist, background in anesthesia. I have nothing to disclose at the beginning because I'll be playing some videos that I claim no copyright to. So when we say airway management, all I'm concerned about is maintaining the pathway from the nostril or the mouth to the beginning of the respiratory tract, the larynx, patent. All I care about is that this pathway is open. I'm really not concerned what we are giving from outside, because whatever you're giving, if this pathway is not open, then the patient is not going to benefit. We'll go through the different procedures to maintain the pathway open, but just keep in mind that this is for demonstration. In real life, we don't do that. We usually approach the patient directly with the golden standard. So this is the first maneuver you can do to maintain a patent airway. We have all practiced this before in BLS. This is called the jaw thrust, using your index and middle fingers on the bony angle of the lower jaw, and you are thrusting the jaw upwards. Sometimes this is enough to displace the tongue away from the posterior pharyngeal wall and opening the airway. The other maneuver, using your hands only, is also learned in BLS, and this is called head tilt, chin lift. Again, using your fingers on the bone of the lower jaw, you lift the chin upwards. This, as you can see, displaces the tongue. If this was the tongue compressing or obstructing the airway on the posterior pharyngeal wall, lifting the chin upwards can displace the tongue and open the airway. Just a small notice here that in the head tilt, chin lift, there is an extension of the neck, and that's why this maneuver is to be completely avoided if you have suspicion of cervical spine injury, which is the case in any trauma scenario or road traffic accident or any kind of trauma. So this maneuver is to be avoided. Now, if we are not successful with that, then we move to something very simple. We call this the oropharyngeal airway. And from the name, it goes through the mouth, oro, and it ends in the pharynx. So the oropharyngeal airways, if you hold one in your hand, are made of hard plastic. And the reason for that is that when it goes through the mouth, if the patient closes his mouth or clenches his teeth or even have seizures, he is not able to obstruct it and occlude it. And this way, the airway is maintained open. As you can see, there are different colorings, and each color denotes a certain size that fits a certain patient. There are some tables like this that tells you which color fits which patient, but we usually don't try to memorize these because we follow a very simple, rough method to see if the airway fits the patient. Just put the airway flushed with the mouth or the teeth of the patient, and its tip should end at the angle of the lower mandible. When we insert the oropharyngeal airway, this is how it should be when it is in place with the C-shaped curvature following the anatomy. But actually, when we insert it in the opposite direction, the other way around. So we insert it with the tip going upwards until we hit the hard palate, and then we rotate as we push in. The reason for that is to avoid friction with the tongue. This is a very short clip showing you how it's done. So this is how it's being inserted. I'm not going to spend a lot of time talking in theory about indications and contraindication. All I want you to remember is the absolute contraindication of an oropharyngeal airway, which is an intact gag reflex. If your patient still has some consciousness and an intact gag reflex, don't think of the oropharyngeal airway. It will simply induce fighting, coughing, and sometimes even laryngeal spasm. So the absolute contraindication here is an intact gag reflex. There are other contraindications, but this is the absolute contraindication. If we're not successful with the oropharyngeal airway, we move to another one, which is called nasopharyngeal airway. So now you understand from the name, it's nasopharyngeal. It goes through the nose this time, and again, the tip ends in the pharynx. If you hold one of these in your hands, you will immediately notice the difference. It's made of soft rubber. You can easily bend it, deform it, and flex it. And the reason we are able to make it of soft rubber is that it goes through the nose. We are away now from the mouth. So even if the patient closes his mouth or suffers a fit or something, he's still not able to occlude the nasopharyngeal airway. And again, you notice there are different sizes. Each size fits a different patient. And again, we don't memorize any tables. There is also a method for the nasopharyngeal to help you detect the proper size. This time, you put it close to the nose, and the tip of the nasopharyngeal should end at the ear lobule. This way, you know it fits your patient. This is how a nasopharyngeal looks when it is in place. As you can see, it's going through the nose above the hard and soft palate and ends in the pharynx. So now, if the patient closes his mouth, he cannot obstruct it. Again, I will not talk about theory here, but again, remember only the absolute contraindication of a nasopharyngeal. It is actually the contraindication of anything going through the nose. Nasopharyngeal, nasogastric tube, nasal intubation. This is absolutely contraindicated if the patient has fracture base of the skull. So for the oropharyngeal, it's intact gag reflex. For the nasopharyngeal, it is fracture base of the skull. Insertion of the nasopharyngeal is quite easy. Take a look at this. I'm sorry. Insert it into either nostril, and it's normally going to be into whichever nostril happens to be your. So introducing the nasopharyngeal is quite easy. we just said that if the patient has an intact gag reflex, we shouldn't use an oropharyngeal. The nasopharyngeal overcomes this problem. The nasopharyngeal is very well tolerated, even by patients who are conscious. This picture, for example, is taken from a video in which this is a famous RT. He has many demonstrative videos. He inserts a nasopharyngeal for himself. This tells you how much it is tolerated by patients with intact gag reflexes, even fully conscious. If both are not successful, then we might move on to another relative of the airways. This is called the laryngeal mask airway, or for short, LMA. The laryngeal mask airway, remember, it's an airway, so it's still one of their relatives, although it looks a little bit complex. It is simply made of this elliptical shaped balloon. This balloon is the part that actually faces the larynx or masks the larynx, hence the name laryngeal mask. And when you inflate this balloon with air through this side port using a normal syringe, when this elliptical shaped balloon is inflated, it creates a seal around the entrance of the larynx. This seal is not always 100%. It is, as they call it in the book, less than perfect seal. Then we have this shaft, and at the end, your end is the universal connector, which can connect to an ambu bag, to an anesthesia machine, to a ventilator in the ICU, whatever. Once more, there are different sizes of the laryngeal mask, and each size fits a different patient. And once more, we are not going to memorize. I will tell you why we don't really need to memorize this table in a minute. Now, inserting the laryngeal mask, actually, there are several techniques to insert it. Personally, I was trained to the classical method, in which you hold the laryngeal mask as if you are holding a pen, and you insert it blindly in the mouth of the patient, pushing with your index finger backwards in order to slide it against the hard palate. And you go as far as your index finger allows you, and then you leave it, it's in place. They call it, it is seated. We'll show you a video of doing that in a moment. This is how the laryngeal mask airway looks when it is in place. As you can see, the elliptical shaped balloon is now masking the larynx, masking the entrance of the respiratory tract. And when we inflate the balloon, as you can see by the syringe, it creates the seal. But we just said that this seal is not 100%. It is not an absolute seal. So sometimes when you are giving oxygen or anesthesia, anesthetic gases, some of what you're giving goes through the esophagus. This inflates the stomach, and this might induce vomiting. And this is the absolute contraindication now for the LMA, which is a full stomach. So if you know that the patient has taken a meal within the last 6 hours, or has taken a non-transparent drink within the last 2 hours, you consider him to be full stomach, and you avoid using the laryngeal mask airway. Non-transparent drinks are like milk, mango juice, but tea, for example, is a transparent drink. So the patient could have taken it within the last 2 hours, and you still consider him empty stomach. So again, oropharyngeal airway, absolute contraindication is intact gag reflex. Nasopharyngeal is fracture base of skull. LMA is full stomach. I will show you why I told you we don't need to memorize the table of the sizes of the LMA, because it's written on each section of the ladder. The black line that you can see running up the center of the laryngeal mask, this is completely the opposite. As the black line around to the center of the mask, this is twisted maximum seal. The laryngeal balloon features a 15mm transparent So you see every LMA has 3 essential informations. The body weight of the patient it suits, the volume of air you have to inject to inflate the balloon and create the seal, and lastly, the straight line on the back that when you align it with the nasal septum or the upper middle incisors, you are sure that it's midline and the balloon is facing the larynx. These information are all written on the back of any LMA. Now, here's a quick clip about the insertion. So you see, when I was trained, I was being trained that when you insert an LMA, you have to keep some air in the elliptical shaped balloon. Nowadays, they don't recommend that. They recommend that the elliptical shaped balloon is completely empty, completely deflated to facilitate insertion. And then you lubricate the back of the LMA. This is the side that slides against the hard palate. And then you insert it blindly using your index to push against the hard palate. You go as far as you can, and then you leave it. It is now in place. Now you inflate the balloon with the recommended volume of air. It's quite simple technique of insertion. There are other techniques of insertion. Just let's have a look. Place the tip of the larynx just behind the So you see, this is a different technique of insertion. No technique is better than the other. It depends on what technique you have been trained to use. But basically, they are the same. Lubricate the back, slide it against the hard palate using your index finger, and go blindly as far as you can. It's in place. This is a special type of LMA called intubating laryngeal mask. I just put the picture so that you know what it looks like, because we're going to mention it later on. It's a laryngeal mask, but once you insert it, you can insert a tube inside it, and this tube goes into the larynx. Then you remove the laryngeal mask airway. It's used in difficult airway management. Now, you notice perhaps that using your hands, oropharyngeal, nasopharyngeal, or LMA, none of these methods actually entered the larynx. The LMA was the closest to come just facing the larynx, but no one of them actually entered the larynx. So all of them are not 100% secure. The only secure device is the device that goes inside the larynx. And this is the endotracheal tube. And that's why it's the golden standard of airway management. The endotracheal tube, this is the patient's side. It has a balloon that we call the cuff, that when you inflate it, again with air through this side port, it creates a seal inside the trachea. This is the shaft, and it also has a universal connector. Perhaps you heard many times anesthesiologists or intensivists talking about size of the tube, saying tube 7, tube 8. This number we are talking about is the internal diameter of the endotracheal tube in millimeters. So when we say a tube 8, this means the internal diameter is 8 millimeters. And it's always written on the shaft of the endotracheal tube. There are different sizes, different shapes, and even different structure. Like, for example, this one, this endotracheal tube is armored. Armored means it has a coil of metal within the shaft. This allows it to bend without being obstructed. You notice that the endotracheal tubes of pediatric sizes do not have this cuff, because when the cuff is inflated and it creates a high pressure against the trachea, in pediatric patients or infants, it causes injury and necrosis to the trachea. So pediatric sizes do not have this cuff. Now, choosing the size is not a big deal in adults. In adults, we usually, for a female, use perhaps even less than 7. I would use 6.7 to 7.5. Now, you know what these numbers are. They are the internal diameter. In a male, I would start perhaps by 7 up to an 8. It's not a big issue in adults. The question is in children and infants. You have to choose wisely because, as we said, sometimes the tube causes injury to the trachea. So the most famous formula is 1/3 of the age plus 3. So if you have a child of age of 3 years, 1/3 of that is 1 plus 3 is 4. So you choose the tube of 4. A less commonly known formula is 1/4 of the age plus 4. Sometimes you use that. For example, a child of 4 years old, 1/4 is 1 plus 4 is 5. So, but this is the most known or commonly used formula, 1/3 of the age plus 3. However, there's something more important than actual only the numbers. It is why you are intubating the patient, the purpose of the tube. For example, in the OR, an anesthesiologist intubating knows that he's going to intubate for the duration of the surgery, 1 or 2 hours, and then he's going to extubate the patient. So he's looking for a tube that fits the patient, but still the smallest size possible, so as to decrease the irritation and injury perhaps to the trachea. In the ICU, we think differently. When we intubate, we know that this tube is going to stay for a few days, maybe a week. So we are looking for the largest suitable tube size. And this is in order to decrease possibility of being obstructed by dry secretions, to facilitate suctioning, and to avoid having peak airway pressure alarms on the ventilator. So your choice of a size depends actually on why you are intubating the patient. This is how an endotracheal tube looks in place. It's going through the mouth. It enters the larynx. That's why it's the golden standard. And once the cuff is inflated, it creates a seal. Now, nothing from outside can enter beside the tube. Suppose the patient vomits or there is bleeding or even just the secretions. And the air you are giving through the tube cannot escape outside. And actually, if you are passing by a patient in the ICU and he has a defective cuff, you can immediately spot that just by the sound, because the air will be escaping through the trachea out through the mouth. As it passes through saliva and secretions and creates a very distinctive sound of air going through water. It sounds something like this. And we immediately, once we hear the sound, we recognize that there is a leak, and the first thing you check is the cuff of the tube. Now, the only problem of inserting a tube into the larynx, this is how the larynx looks like. These are the vocal cords. The space between them is the glottic aperture, and beyond that you can see the trachea. Now, the only problem is that there is no direct line of vision between your eyes and the vocal cords. So you have to use another instrument to show you the larynx, for you to be able to see the larynx and to get this view so that you can insert the tube in. And this instrument is what we call the laryngoscope. Now, laryngoscopes come in different models and shapes and sizes, but basically there are two main types of laryngoscopes. The one with curved blades, and this is called Macintosh, and the one with straight blades, and this is called Miller. Now, we don't have Miller in our adult ICU. It's most commonly used in pediatrics. So the most commonly you will see is the Macintosh. But there's a very important difference in the way you use them. With a curved blade, with the Macintosh, you have to place the blade in the proper position. And the proper position is exactly this point. Anatomically, this point is called the vallicula. It is the common base of the tongue. This is the tongue here, and the epiglottis. So the vallicula is the point of meeting of the tongue and the epiglottis in order to raise the epiglottis upwards to reveal what's beneath it, which is the vocal cords, as you can see. Why placing the blade above the epiglottis allows you to raise it? It's because of a small ligament here, as you can see, called the hyoepiglottic ligament. It's between the epiglottis and the hyoid bone. So once you press with the tip of the blade on that ligament, the epiglottis lifts upward. You know, just like moving a marionette. When you want to move the marionette, you just pull the string. So this is the same way. You are pulling the string here, which is the hyoepiglottic ligament, by placing the blade in the vallicula. Then the classic laryngoscope got developed. They changed the light bulb with the camera, and the camera displays on a monitor, and this is called a glidoscope. And then there is the video-assisted laryngoscope. It's also using a camera, but the camera displays on a small monitor on top of the handle. But basically, they follow the same principle. You have a curved blade and you have the handle. So I'm going to show you an animation, actually, of how to use the glidoscope to intubate.
Video laryngoscope, designed for first-pass success. A four-step technique to glidoscope video laryngoscopy combines direct vision of the patient with views on the glidoscope video monitor. Start by looking in the mouth to introduce the laryngoscope. At the screen to obtain the best glide view. Back in the mouth to introduce the artificial tube. And finally, at the screen to intubate. Begin step 1 with direct vision, looking directly into the patient's mouth. The patient appropriately positioned and with the glidoscope video laryngoscope in left hand, introduce the glidoscope into the midline of the larynx. Gently advance the glidoscope until the tip of the laryngoscope is past the posterior portion of the tongue. Conventional laryngoscopy, the glidoscope video laryngoscope is introduced midline. No lateral displacement of the tongue is required. Step 2 is performed while viewing the video monitor the entire time. With the glidoscope inserted, look to the monitor to identify the epiglottis. Then manipulate the scope to obtain the best glide view. The glide view is optimized by a combination of advancing and withdrawing the laryngoscope slightly, while increasing the tilt to see the device in the molecular or on the posterior ceiling side of the mouth to obtain the best glide view. When the glidoscope video laryngoscope is appropriately positioned, the glide aperture is centered in the upper third of the video display. This optimal view in the display is achieved using minimal force of the tube. patient's open mouth and not at the video monitor, blocking the passage of T to help with potential injuries in the transverse upside down. The undertaking tube, which in this case is shaped by an upright rigid cylinder to outline the angle of the broad-scope video laryngoscope, is inserted under direct vision until the distal is within the distance of the laryngoscope. This relationship is quickly and easily achieved, and only then should we return to look at the video monitor. In step 4, focus on the video monitor as you advance in the returning your eyes to the video monitor gives you a view of the right aperture and near it, the tip of the underturning tube. Sometimes a step withdrawal of the gyroscope is required to reduce the movement and allow the glass to dry. The tube is then advised by gradually withdrawing the style of 5 centimeters as the tube moves forward. Doing the entire insertion step on the video monitor allows you to quickly and gently rotate the tube without having to redirect the signal. To review, the 4 steps to successful gyroscope video laryngoscopy are: in the mouth to introduce the laryngoscope, at the screen to obtain the best live view, in the mouth to introduce the undertaking tube, and at the screen to intubate.
So these are the steps you actually follow to intubate. So mouth, screen, mouth, screen. I will show you another video that walks you through the actual landmarks that you visualize while inserting the glidoscope until you are able to visualize the vocal cords and the glottis.
Place the gyroscope inside the patient. There's the video. You might not, there's the parents. This is the posture and back of the parents. That's the top. Go to the deeper. That's the tip. That's the glass. That's the here's the structures of the and then and then we got the
So I hope you noticed the importance of the proper placement of the handle in the vallicula. If it's in the vallicula, then you don't see the tongue anymore, but you can see the epiglottis because it's below the blade. And the other thing, I hope you noticed the importance of a proper size chosen because you see that the tube, as it goes in, it has some friction or rubbing against the vocal cords. So if it's too large, it might later on cause edema of the larynx and the vocal cords. This is a fiber optic laryngoscope. It's used in difficult airway management. I think it's beyond the scope of this talk. But now I want to go through very quickly the algorithm of airway management in a COVID patient, since we are in the COVID patient era. Now, the most important thing in airway management of a COVID patient is planning, is having a well plan before starting the management of the airway. And the reason for that is that you want to minimize the duration you spend managing the airway, because this way you decrease your exposure and the risk of getting the infection. So it has to be very well planned. And that's why, for example, in KSMC, we developed our own protocol. We developed our own team of airway management for COVID patients. As you notice, the algorithm starts with talking about rapid sequence intubation and then having a very good plan. So we must know who are the people in the team. They must have a checklist of all the items they need or they might need during the airway management. Everything must be prepared. The personnel themselves must be very well protected using the proper PPE. You must prepare your patient as well with pre-oxygenation. And I want to remind you here again, someone has posted on Twitter, I think, there is no emergency in a pandemic. What he meant by that is that if you have a patient who is crashing and needs immediate intubation, there is no need for heroic actions. Don't say, I will jump immediately inside the room to intubate the patient. No, first protect yourself. First put on your proper PPE before approaching the patient. There's no point trying to intubate the patient as an emergency without being protected, and you yourself and your team catch the infection and then you spread it, then you have actually caused more damage. And that's why different hospitals and different authorities have developed like the team for the airway management. We in KSMC have a team similar, very similar to the one I'm going to show you now. So as you saw, it's a 3-member team. Just like Dr. Saima told us, it is recommended that the most experienced airway manager, preferably an intensivist or an anesthesiologist, is the one who handles the airway management. And this is again in order to minimize the duration and minimize the aerosol generation during the procedures. Other places have different team formulation, like this team, for example. The difference here, it's almost the same. We have the most senior handling the airway, 2 assistants. One is responsible for the medications and the instruments and assists, and the other one probably for documentation. But this team also has the 4th member who is standing outside. They call him the clean member. As you can see, he's not wearing the full PPE and he's outside the room. His role is to help them if they need, for example, something that they haven't prepared or they need to call for help. He can run and get the help. The most important thing is following the checklist. Prepare everything ahead before approaching the patient. In this video, I'm not going to show it to you from the very beginning, but I want to show you the parts that are very important. They stress on the face bag or ventilation. When you have to do this for a COVID patient, it is recommended to be negative pressure, without active bagging. This is again to minimize aerosol generation. But if you must do it, the patient is desaturating, for example, then it has to be two-person. One handles the mask to fit it very fitting to the mouth and nose of the patient so that no aerosols escape, and an assistant will do the bagging. The other thing is, once you intubate the patient, do not connect the ventilator unless you have inflated the cuff, again to minimize aerosol generation. If you are switching the patient from a ventilator to an ambu bag, for example, to transport him, or from the ventilator in the ICU to a portable, you must clamp the tube during inspiration before you disconnect. Have a look at this.
Our side is used to avoid back masking the patient for prevention of aerosolization. Here, avoiding coughing with prolonged relaxation. Successful, it is important to then reach out to the person outside the room if you are transporting an intubated patient to the ICU, make sure that the or disconnect or reconnect your back valve mask. We're saving our transport ventilators to space.
So these were very important tips: clamping the tube before disconnecting, inflating the cuff before connecting to the ventilator, and if you must bag mask the patient, you have to do a two-person maneuver. Another very important tip, perhaps you remember how we used to hold the mask when we were being trained in BLS. We used to call this the C and E. So this is the C, and these 3 fingers are having the E. Now, this is not the method to handle the mask that is recommended in COVID. What is recommended in COVID is the V way of handling the mask. This is called the V because these 2 thumbs will form a V shape. And this is because this part of your palm is much stronger and can have a better fit of the mask on the patient's face and nose. So always remember, the way to handle the mask in a COVID patient is the V, not the C and E. Now, you remember the beginning of the algorithm was rapid sequence intubation. Now, rapid sequence intubation, in my opinion, is all about good planning. So everything must be prepared ahead. So you can see 4 prepares. Prepare the patient, have him in the proper position, have him well oxygenated, have him well monitored, and then prepare all the equipment you think that you are going to need during the airway management. Also be prepared to face difficulty. Have other instruments that might help you in difficult airway management, but this is a completely different algorithm. And then prepare the team. The team should be there, well protected. Each one has his proper donning, and it's even recommended that we visually check each other and comment on each other. If you see that your team mate is not doing his proper PPE, you can tell him, please do that again, please properly position your mask, and so on. And each member of the team should know his or her role. So this is mainly the rapid sequence intubation. And then we start to proceed. I don't think this is very important in the scope of this talk, but these are the medications that we usually use in rapid sequence intubation because they have a short duration to be effective, to act upon the patient. The only thing I want to stress upon is that you make sure that your patient is in anesthesia, is asleep, before you start to give him muscle relaxation, because otherwise the patient will have a very bad feeling of being paralyzed while he's still awake. The other thing is that we must make sure the patient is well relaxed. This is to avoid coughing while we are manipulating his airway. This is a time sequence of the rapid sequence intubation, and perhaps you can see there are about 10 minutes of planning before we approach the patient, before we reach point 0, when we start to intubate. But then the intubation itself should not last more than 30 to maximum 45 seconds. So we took our time planning and preparing everything, but once we started, we have to do it within seconds, within less than a minute. In rapid sequence intubation, we used to memorize the 9 Ps, which was, again, about preparation, about protection of the cervical spine, that is the positioning of the head of the patient, the pre-oxygenation, the different medications we give, the intubation itself, and then verifying its position, and then post-intubation management. There's another P that is called cricoid pressure, but actually this is questionable. So let's go back now to the algorithm. Now we understand what is rapid sequence intubation, what is meant by the checklist and the team preparation. It is recommended that we intubate a COVID patient using a glidoscope, not the classic laryngoscope. This is to stay away from the airway of the patient. And then we move to plan A, which is the classical attempt of intubation. If this is successful from the very beginning, well, that's very good, and the algorithm ends here. But the question now is, what if we fail our first attempt to intubate? If this happens, then you ask yourself a very important question. I am not able to insert the tube. I failed to intubate. But can I still maintain ventilation of the patient? Can I still do it with apneic CPAP, This is without active bagging. Can I still do it with a face mask ventilation or even a supraglottic device, such as the laryngeal mask? You ask yourself, can I still do that? If the answer is yes, you can still maintain the oxygenation, although you are not able to put a tube, then you might be slightly relaxed because you're not going to lose the patient. So if the answer is yes, you are going to move to plan B. Plan B is simply, is the situation okay for me to try one more attempt, but this time you change something. Maybe if you haven't already done that, you put a stylet in the tube, you use a larger blade, you properly position the patient. Is there enough time for me to try one more attempt? Or if you think that you have already done that and there is no time to perform another attempt, the patient is crashing, then you can move to plan C, which is called exit options. Exit options, which is you're trying to find an exit out of this situation. And how do you do that? You think of inserting a supraglottic device, the laryngeal mask airway, for example. You must for sure by now call for help and maybe get the help of someone who is more experienced. Or if this is all not successful, then you can go to what we call surgical airway, obtaining an airway through a surgical procedure, which is here, the recommended one is bougie assisted. But remember, we are slightly relaxed here on this pathway because we can still ventilate the patient. The problem is when you fail your first attempt, but you are also not able to ventilate the patient without the tube. So this is a real emergency situation. This is the situation we call cannot intubate, cannot ventilate. This is a real emergency because if this is prolonged, we're going to lose the patient. Remember, our patients in the ICU are usually very fragile. They have very limited reserves. So unless you do something very quickly, you might move into an arrest. So in this very risky situation with cannot ventilate, cannot intubate, first thing you do is call for help. You don't hesitate to call for the help or to ask for the help of someone who is more experienced. Now, it's your judgment. Do I consider an attempt with the supraglottic? Do I attempt another trial with the face mask ventilation using the two persons technique? Or there is no time for that, and then you immediately move to the bougie assisted cricothyrotomy. Now, decision making here is very important. It has to be done within seconds. Otherwise, you're going to lose the patient. I'm going to show you a video clip on how to do the bougie assisted cricothyrotomy or obtaining the surgical airway. So perhaps you noticed that the procedure is done by military personnel. This is what they are being taught in the army, because this technique is the quickest and the fastest that they can use even during battle, in the battlefield. This is opposite to another very, very closely similar method of obtaining a surgical airway, but this one uses a guide wire. I think we have enough time to show it to you. It's a very short clip. It depends on using a guide wire, just like when we insert a central line.
Dr. Walid, 5 minutes left, please. Walid?
Yes, Dr.
Because 5 minutes left.
This is the last thing.
Okay, thank you.
So perhaps you noticed that this technique is very similar to the bougie assisted, but maybe it's a little bit longer in duration. And that's why the recommended method of surgical airway with a COVID patient, as always, we are trying to minimize the duration. So the recommended method is the bougie assisted. With that, I conclude, and I thank you very much. Always remember the A of your ABCs, that's the airway. Thank you very much, and I've concluded, and I'm ready to take questions if there are any.
Thank you, Dr. Walid. Please, if there is anybody has any question, we can write it in the group.
So thank you. I also thank you very, very much, and I hope this was helpful, and enjoy the rest of your meeting.
Thank you so much, Walid, actually.
Thank you, Dr. Ahmed. Thank you very much.
Your lectures,
always
lecture,
support.
The beauty of your lecture and the video simulations, it can we can get rid of workshop actually. It is enough.
No, but actually, Dr. Ahmed, in a real workshop, having the participants doing the maneuver or the procedure themselves is really, I think, a good experience.
Yes. We will do the workshop inshallah, but when you will join the ICU, we tried to announce for workshop last week and we did already once.
Yes.
But we did find there is no more compliant with attendees. For that, we decided.
I told you, Dr. Ahmed, we should have done it على السحور.
Not we will decide. Already first batch will join to our ICU inshallah Sunday. Already we have first batch, and from the next week, sooner all of you will join the ICU. So once you will join, it will be easy. It will be easy to conduct the workshops.
No problem.
On a small group instead of making a large group. We have question here from Dr. Amir.
Of course.
Can we do tracheostomy for COVID patients?
You mean tracheostomy as a percutaneous planned tracheostomy or as an emergency surgical airway? If it's an emergency surgical airway, we just saw that if you reach a dead end in the algorithm, you cannot intubate the patient and you are not able to ventilate him, then you do it just like we saw as a cricothyrotomy. But about a percutaneous planned, maybe Dr. Ahmed can answer this question better than me. And I think yes, no problem with that.
Yes, the problem with percutaneous actually that you open the trachea blindly with aerosolization. The problem with gas dispersion or air dispersion during blindly open the trachea during ventilation. So it is a highly aerosolized procedures. But if you are doing it with dissection in OR or by ENT, it will be less aerosolization. This is the issue behind the tracheostomy. For emergency, it is preferable to have cricothyrotomy bougie guided or styled guided. As you can see in the video done by Dr. Walid, insertion of the bougie, almost you have a leak, you have a tight seal around the bougie as well as around the tube. So we have a very less chance for the aerosolization around the tube. Right?
How long can we keep the cricothyrotomy? You keep the cricothyrotomy for as long as you need the airway, as you need the maintenance of the airway, but then you start replacing it by something that can last longer, perhaps a tracheostomy tube.
Yes. Thank you so much. Actually, again, I will announce that the protocols and the algorithm for everything, once you will join, we'll do like hands out. It will not be a hardware, it will be a software in your group. The people joining us, we will post in your group the all algorithms and the COVID protocol you see in the lectures as well as the cluster COVID. It will help so much during your practicing in ICU. And you will be attached or linked with ICU. You will not join direct alone with the bedside patient with COVID. First, you will be with non-COVID patient, then you will join. Once you feel competent, you will join to the COVID patient. We will be attached always with the ICU. And your help will be greatly appreciated actually, because we have shortage currently so much. So thank you. If you have any queries, because I will leave with Dr. Ahmed Kuhail now. The video airway with sound to share. Everything will be recorded already day by day as Dr. Ahmed Kuhail is sending, and it will be sent to your group, a recorded lecture.
Of course.
Any queries before we proceed with we'll continue the course? Thank you. Kuhail, you are available.
Thank you very much.
Thank you so much. Dr. Ahmed, now you can explain to them the rest of the course.
Because now supposed to be the lecture for Dr. Omar, but actually he's apologized for the ARDS because he has some emergency now in the hospital. So he's apologized. So I may just to present his lecture as we take a permission from Dr. Omar.
Omar?
Yes, because he's apologized actually.
It's okay, but we can send the recorded one before to the group, or you have the slides?
Yeah, I have the slides already.
Yes.
Okay.
We can go through if you like.
Okay, Doctor. Assalamu alaikum. So this is actually the lecture of Dr. Omar. Just because he has an emergency, we are presented on behalf of him. So here, this is the topic we will discuss about acute respiratory distress syndrome. Actually, the definition, it was the initial definition 1994 as per American and European consensus comfort. It's an acute presentation with radiological criteria showing there is bilateral infiltration with consisting of presence of edema. So this is the X-ray for the one patient who has bilateral infiltration pulmonary edema, not cardiogenic, because here as the Berlin definition it was defining as the time, there is multiple important things you have to keep it in our mind to define the patient his ARDS. Number one, the time, it should be within 1 week of the presentation as it's a new onset, worsening of respiratory symptoms. The other issue, there is finding in the imaging, either by X-ray, ultrasound, CT, showing there is bilateral obesities, and there is not fully explained by fusion or collapse or reduce. So there is mainly bilateral obesities or infiltration, consolidation. The origin of edema should not be cardiogenic, as like, for example, if the patient he has heart failure, decompensated heart failure, there is pulmonary edema, it's not considered as ARDS. Should be ruled out this edema to be underlying caused by heart. So they are dividing actually the oxygenation into 3 categories: mild, moderate, and severe. According to the BF ratio, the BaO2 divided by FiO2. So actually, if it is the mild, if it is around more than 200 to the 300s, with the beep more than 5 requirement. But in the moderate, it's between 100 and 200, but severe less than 100. So here the divide according to the BF ratio, which is very important because we will know the prognosis of the patient and the management, how it will be according to this BF ratio. As you see here in this table, the mild cases with the BF ratio 200 to 300, the mortality is 27. But in the moderate, reach 32, in severe, reach up to 45%. So here, what are the most common causes of ARDS? The most common causes, can be pneumonia, sepsis, trauma, and inhalation injury. So the causes of ARDS also, as you see in this distribution, pneumonia is the majority. It's representing 40%. The second one, sepsis, 22%. Then it go for the aspiration pneumonia, 15%. And there's other causes, trauma and transfusion, blood product transfusion. So here, the cause of ARDS, including also direct, or can be divided by mechanism, direct or indirect injury. The direct injury, like pneumonia, as what we have now, the COVID-19, so which is called now by Professor Gattononi COVID-19 ERDS, and gastric aspiration, drowning, severe thoracic trauma, and fatty embolism. And indirect way, like the patient, he has severe sepsis, multiple blood transfusion causing trali, shocks, keratitis, drug overdose, BIC pictures. So all this it can indirect way. So here there is some ventilator strategies we have to think about it, because the ERDS now protocol we are going, which is called lung protective strategies. So this is the lung protective strategies. It's to keep the alveoli healthy as much as we can and to avoid ventilator-inducing a lung injury, either by attractive trauma or volutrauma. Because this is, if you can see in this, the first, how is the alveoli is distended, and which is the risk for volutrauma and pneumothorax. And if you can see here, if the alveoli is collapsing and attractive trauma. So when we are keeping the high beep and high tidal volume, especially the high beep, we can induce more pneumothorax and volutrauma. But if we are under ideal beep for this patient, because the ideal beep is different from one patient to the other, so you have to personalize your patient according to the clinical assessment. So if you keep the beep is low, there is more atelectasis, more desaturation, it will be worse the condition. So you have to optimize. If you see in this area, it will be the safe, less risk of volutrauma and less risk of attractive trauma. So this is the picture of attractive trauma actually. So if you can see, this is optimized lung. In this patient, he has ERDS, and they did CT for him. It was for the big with his 30 kg, the module. So it was here, the beep, actually it was 5, but after they put the beep is 25, which is actually, it's high. See how is the alveoli it's opening now in comparison to the previous one. So there is more aeration of the lung, but there is some area it's hyperinflated in this CT. So if they put it 40, it's more opening the alveoli, but also if you can see more aerated in ventral area, but in the dorsal it's opening more. So here in this diagram, actually, we are going to lung protective strategy is very important for the patient with ERDS, as we mentioned, to protect the alveoli from ventilator injury. As if the alveoli is more distended, it will can cause volutrauma or biotrauma. But also, if you underestimated the PEEP or positive end expiratory pressure, it can cause more atelectatic trauma. And if you are giving the patient high oxygen, which is unnecessary, like you are giving the FiO2 200 and you will find saturation 100, and PO2 you will find it, for example, 200. This is going with oxygen toxicity, which can harm the patient and induce ventilator-induced lung injury. So all of these, it can affect some other organs dysfunction. So here in this trial, actually, it was published in New England Journals in 2000. They have these two arms. They have the intervention group and the control group. The intervention group, actually, the tidal volume, they are keeping between 4 to 6 millimeters, the ideal body weight, and they are comparison to the patient who has a beep of 10 to 12 with the tidal volume, 10 to 12 of ideal body weight. It's not the actual body weight. If you can see this one, like this patient, his body weight maybe around 150, you will not calculate the tidal volume according to the actual body weight. So we will have to calculate the ideal body weight, because the lung size will be affected according to the height mainly, not according to the weight. So according to the height, according to the gender, male or female, if there is any deformities, it will be. In this equation, actually, you will find how they are calculating the predicted or ideal body weight according male or female to calculate the tidal volume. This is an approximately for the male who has 75, how they are calculating, multiply by 4 or by 6 according to the target volume. So if the patient going for lung protective strategies, actually we are preferring to gradually decreasing, like if the patient was on tidal volume 8 milligram per ideal body weight, so we will per kg of ideal body weight, we will go down for 7, then we will go down gradually until to achieve our target. What we are looking for, we are looking for the plateau at the same time. The plateau pressure, as you see here in the lung protective strategies, here the targeted plateau should be below 30. The optimal even should be below 28. But below 30 is the acceptable, because if it is more, it will be more lung injury, and it can induce also pulmonary hypertension and right ventricular failure. So it's better to optimize to keep it below 28 is better. So in this study, actually, it was done in multi-center randomized controlled trial, and 862. If you see here the difference between the lung protective strategy and the mortality effect, it was 31%, while in the conventional therapy, we found the mortality is 40. So there's significant reduction in mortality with lung protective strategies. So this is here, actually, we have all the RTs, they have this table, and they are working on that. And then even our protocol for ARDS patient for COVID-19, we have this protocol. So here in this trial, if you can see again how is the outcome in the mortality in 28% in the high peak, high tidal volume and low tidal volume. The high tidal volume is reached up to 40, while in the low tidal volume it will be 30. So there is significant reduction of mortality side. See, now in this question, we are going to, this case actually 28 years old patient. He has ARDS with secondary to severe pneumonia. The patient ideal body weight is 70, and the tidal volume is taking is 420, which is equal 6 ml per ideal body weight. And respiratory rate is 18 for time he's taking. PEEP of sit on 12, and FiO2 is 80%. The APG now showing the pH 7.28 and PO2 76, BCO2 57, and saturation is 92, and the bicarb is 18. So what should we do now? So are we going to keep the current setting as it is, or just we will increase the respiratory rate for 22, or you will increase the tidal volume, or to give sodium bicarb? So you can write in the chat, please. So if you notice here in this case, actually, it is, the pH is 7.28, which is acceptable in ARDS protocol, as we are allowing for permissive hypercapnia. So because so cost should be paid here, as permissive hypercapnia, it's allowed in ARDS. So the people in ARDS, What is the optimal beep? As we mentioned, you have to personalize your patient for ARDS. Not all the patients, they have the same beep. Because if you see here the beep of 0 and beep of 40, if you go with lower beep, like beep of 0, you will find there is more atelectasis and less risk of inflation. While if you give higher beep, you will be risk more volutrauma and less risk for affected trauma. So you have to reassess and personalize your patient according to the optimal beep for them. So here in this randomized control trial, actually it's they are comparing 549 patients with ARDS and acute lung injury. Actually, the comparison between lower beep or higher beep. Actually, all the received tidal volume of 6 ml per kg of ideal body weight, and they keep the plateau pressure below 30. So here they found there is hospital mortality. It was 24.9, almost 25% comparison to 27% for higher beep. So there is no statistically difference because the PE value was 0.48. So this is with the low beep, this is with the high beep. So there is no difference actually. So here, this is the patient who has comparison between the variable high beep and the low beep. Actually, you can just find in the numbers. When you give higher beep, you will find the BF ratio is getting higher. For example, here the beep is 9, and you will find the BF ratio is 168. But when you give the beep 14.7, you will find the BF ratio is higher. So you can feel there is improvement, there is better oxygenation, which is true, but the outcome actually is not significant difference. So here for this the same patient again, the patient is now in CMV mode, control mode. The FiO2 is 100% and the beep of 12. Tidal volume is 420, respiratory rate is 20, plateau pressure is 32. APG now is 7.18 and PO2 is 55, BCO2 is 59, and bicarb is 18. Saturation is 85. So what is the next? What you will go for? You will increase the beep more, or you will do proning, or increase the tidal volume, or put the patient DNR. You can write in the chat, please. So we can take it one by one. Here, what's our target? Actually, we said should be the plateau pressure less than 30, and the tidal volume it should be 6 ml per ideal body weight. So here, the plateau pressure is almost 32, which is high. If you increase the beep, the plateau automatic will be increased. So you'll be more harmful. So it will not be the good option. If you go to increase the tidal volume, again, it will increase the plateau pressure. Okay, it will improve the CO2. When you increase the tidal volume, the CO2 will be washing out more, but it will harm again in the opposite side for the plateau pressure, because what are the controlling the plateau pressure? Mainly it's affecting by tidal volume and the beep. So both of them, any changing, it will increase the plateau. So this is two, it's out. So put the patient is DNR. Still, we have a rule, we can manage the patient. There is other modality of therapy. So the prone position actually is the recommended, because if you calculate the BF ratio here, it's less than 150, which is an indication for proning position. So what is the next? Prone position. This is the ideal one. The other modality, there is ABRV modality, they can use it, or HFO, high frequency oscillation, or nitrous inhalation, and the other to go with ECMO. So here, when we have to consider using a secure therapy of refractory hypoxemia. So there is no definite definition for refractory hypoxemia, but we can say if the PO2 less than 50, if IO2 requirement more than 70%, and it's actually persistence more than 24 hours, despite the PB trial to 20, reaching 25 with some recruitment maneuver, and ruling out other causes. So here this is the busy slide actually, but we can but the pathway for ERDS with severe hypoxemia, as we mentioned here, the protective lung strategy should be applied. The tidal volume less than 6 ml per ideal body weight per kg, and the target plateau should be than 30. So if this it's not achieved, so we have to adjust the ventilator setting to adjust the tidal volume, should be less than 60, and to adjust the plateau. How we can adjust, we set the plateau, we can play on the tidal volume and the PEEP also. So if the patient has still severe hypoxemia is there, if no, okay, so we achieve that our target, so it's not refractory. But if it's still refractory hypoxemia, we have to check our cardiovascular statement. So we might go urgent echo bedside, we can do it to assess what is the other causes for that. If the patient has left ventricular failure or left side heart failure, if there is any problem in the left atrial pressure, increasing the high pressure. If yes, so we have to go for diuresis the patient after assessment if his volume status is high volume status. So if there is still severe hypoxemia, if the severe hypoxemia is corrected after this diuresis, so we are now out of refractory. But if it still persists, we have to go again to check the central venous oxygenation VO2. Go check about the volume status. Maybe the patient is hypovolemia. Check about maybe the patient hemodynamically unstable, he is hypotension. So we have to manage the fluid status, resuscitation, vasopressor maybe need to be added. So after that, we will assess again if it's still the same persistence hypoxemia. We can assess now for the right heart failure. Maybe this is pulmonary hypertension, especially with the ERDS, severe ERDS, it can cause acute right ventricular failure, or pulmonary embolism can cause associated with that. Or the patient, he has volume overload also, it can cause right ventricular failure also. So we have to optimize and assess again. So here in this, the continuation of this slide, if still the patient, if the patient hypovolemia, hypotension, we will, as we mentioned, we will assess accordingly. If there is the right side, the right assessment, the right heart failure, if there is, we have to manage it accordingly. Like if the patient volume overload, we will diurese him. If he needs some time electropic support, especially who has reducing contractility. If the patient, all these managed, so we will go now for the sedation. So maybe you will go for deep sedation to add the neuromuscular blockade, because it's you are not allowed to put the patient in a neuromuscular blockade without deeply sedated for the patient, because it's not fair to paralyze someone and he's feeling around and feeling the pain. So if the patient still he has refractory hypoxemia, so we can go the rescue therapy, prone position. So if not responding to the prone, we will go for other. Like this patient, while he's in supine position, when we put him in the prone, see how is the consolidation and aerobronchogram in the lower, in the dorsal, with atelectasis also. While once you put the patient in the prone position, because this is the proning position causing as a recruitment for the atelectasis dorsal area, and it will improve this secretion coming from the dorsal to the front actually, which improve the oxygenation and distribution of this edematous. So this is just reverse what happened for the patient. All the secretion and the edema it will be improving. But actually, even the prone position is very helpful for the patient with COVID-19 positive. Even awake proning, it's very helpful. So here we will go again for another trial, ProSiva, which it was published in New England Journal.
مش عارف ايه. Ahmed, 5 minutes يا أحمد.
Okay, we are about to finish. So this is the 466 patient, severe ERDS. They discuss about the prone position versus supine position. The prone position, actually, it was showing there is improving in the mortality. So it was significant mortality improvement in 28 days and 90 days. And it's causing less cardiac arrest, and there is no difference in the complication. So here there is another scenario. This is a 7 patient, the same patient actually, with FiO2 70% and PEEP of 14. Respiratory rate is 22. Plateau pressure is 32. His ABG showing pH 7.29. PO2 is 85. BCO2 now 49 and saturation 94. So what's the next? Keep the patient prone for another 16 hours. Put the patient supine for 8 hours, then prone again. Prone, prepare for ECMO, or increase the respiratory rate and give sodium bicarb. So you can write in the chat, please. So actually now the patient already is in BO2 85 and the BF ratio is 70. So here the BF ratio around 120. So this patient is some responding for that. So we continue for him the proning. But as you mentioned, it should be supine 8 hours and again prone cycle. So the correct answer here is number 2. But if the patient is still hypoxemia, the BF ratio is very low, less than 60 or less than 50, for how many hours we might consider ECMO for them. This is one of our patients with Dr. Omar. He was in ERDS and prone. After that, he's thanks God he's discharged from ICU and with early mobilization, and he's improving. So actually the proning is improving the oxygenation, about 2/3 of all treated patients. And there is no improvement in the survival and the time of ventilator or the time on ICU, but might be useful in the treatment of refractory hypoxemia. So there is maybe optimum timing and the duration. We need to, this is the question. And there is routine use is not recommended. So here this is the ABRV. I think because of the matter of time, we will skip it. And HFO ventilator, actually, it's other modalities, which is off-label, but actually we find in some refractory patients, if they are not candidate for the ECMO, you might get benefit of that. So I think we will stop now because still there is remaining the exam. Here, this is the algorithm actually for the COVID-19 patient with ERDS. See here if the patient intubated mechanical ventilation with beep for 10 and tidal volume 6. So we will titrate the BF ratio, our target 88 to 92. Then we will see how's the BF ratio. If it is more than 150, so we will prepare him for see the weaning, how's taking spontaneous breathing, how's the bottom of the breathing, how's the FiO2 requirement. So if not winnable, so consider for early tracheostomy. And if the patient, the BF ratio is less than 150, so here we will go according to, because now we have two phenotypings as mentioned with our consultant, Dr. Waqas and Dr. Balshi in the last 2 days. According to the compliance, so we'll go for high beep or low beep. So according to that, we will follow even the ERDS protocol accordingly. If the patient not responding, so maybe we will consider for them the ECMO. So thank you for lung protection, and thank you for everyone to attend this course. If you have any question, you can just write in the chat room.
Shukran, Ahmed. Thank you so much. We have question here. We read that some, Ahmed, you are with me, right?
Yes, yeah.
We read that some proning position before invasive mechanical ventilation. Is it effective? Would you like to answer?
Actually, the awake proning is actually, it's very effective for them. We see a lot of patients, once they are putting in the prone, the oxygenation will be decreased, the requirement of oxygen, even the work of the breath will be decreased. So it's very helpful for them.
Yes, I'd like to add, actually, don't worry about the acute hypoxemic respiratory failure or ARDS in COVID patients. We have a specific protocol, step by step, from nasal cannula until oxygen, until face mask, another breather, high flow nasal cannula, proning, awake proning, and of course non-invasive, even if you have to use it, for how long you have to use, and the invasive ventilation and the setting and the proning and the ECMO, all the steps present in algorithm we will post for the people who will join in the protocol. So because we have special phenotyping, special consideration for COVID ARDS patient based on the stage and the phases when he will come. Either his compliance is high or low. So don't bother yourself a lot with the details of the ARDS COVID. It will be very easy to deal with it. Just you will go through it. Just know now, what we need from you now to know the terms of the ARDS, of the compliance, what's the blood pressure, proning. So early proning as a general, either awake patient, they call it currently nowadays happy hypoxemia or silent hypoxia. Those patients coming with respiratory distress, as Dr. Ahmed said, the work of breathing will decrease and oxygenation improving while he's awake proning. It shows some effectiveness, and we are doing in our protocol. Right. So it is effective actually as well. And also don't bother yourself with the pathophysiology behind and the mechanism, whatever the VQ mismatch or what, improving the perfusion or improving the collapsed alveoli. Okay. More questions? If you have any queries, you can ask. I think, Ahmed, this is the last lecture, right?
Yeah, this is the last lecture.
Yes. You have any question for the course? We send you the survey for the feedback. Kindly fill it and send it back to us. And based on your attendance all over the last 3 days, which is monitored by the Zoom, and Dr. Ahmed will retrieve it from the Zoom, as well as the MSQ will done now. Inshallah, the certificates will be released for each one of you. And I think we have your base hostel, yes, because almost we'll try to make assignment in your hostel, in ICU in your place, without rotating in the cluster hospital yet. We'll try to do like that. You have any comments, Ahmed?
Just now we will release the link on the group. So we'll give him 40 minutes. It's after that we will close the links. Kindly please write your name as in you will be in the certificate. Full name, not only just the first name. Full name, please, to be written as the certificate accordingly to be released.
Okay. Any comments, ya shabab? Any question you want to ask? Thank you so much. Actually, I'd like to thank Dr. Ahmed Koher, Dr. Abu Takin, co-directors, and Christine Emiliana, coordinator of the course, as well as all the faculty of the course, all of the speakers. And the special thanks for all of you for your presence with us in this surgery plan. Thank you so much. Now the link. We have the link here, please, Ahmed? Dr. Arish asking if you can post in the chat room. I will try it. We can do, right?
Okay, I will try, Dr. Just.
Did you post, Ahmed,
Posted now, Dr.
Yes. And the WhatsApp and here, right? Yes.
Yes, and both of them, Dr.
Thank you so much.
Yeah,
so both is in both, shabab, inshallah. It's very easy questions. All of the question present